Welcome, everyone. Bienvenidos. We thank you for joining us for this virtual UHealth International Medical Series presentation, Advances and Innovations in Otolaryngology, featuring distinguished otolaryngology experts from UHealth, University of Miami Health System. I'm health journalist Ileana Bravo, and I will be tonight's program moderator. We're proud to say we have about 24 countries represented here tonight of participants. And we want you to know that our experts are ready to take care of your patients in one of our 5 Florida facilities for in-person consultations, second opinion consultations, or via telemedicine from the comfort of their home. To refer a patient, we invite you to contact UHealth International at 305-243-9100, by email at uhealthinternational@med.miami.edu, or by visiting uhealthinternational.com. Tonight, we're proud that we are going to hear from 3 experts who will share emerging otolaryngology innovations and how they can be used to help you provide the very best care for your patients. Dr. Frank Cevantos will present minimally invasive techniques in head and neck surgery. Dr. Corinna Levine will present clinical rhinology research and skull-based care advances. And Dr. Adrien Eshraghi will present overcoming hearing loss by cochlear implant surgery. Now, during the presentation, we're going to poll the audience, so please pay close attention on the topics because they will be relevant to this discussion. Your responses will be anonymous, but we encourage you to participate. In addition, throughout the presentation, you have the opportunity to ask our panelists anonymous questions using the Q&A feature at the bottom of your Zoom screen. Take a moment, depending on the computer that you're on, to locate that. It has 2 thought bubbles, Q&A. And that's how you're going to enter your questions. And we are going to tee them up and prepare them for our panelists to address at the end of the presentation. So with that in mind, I'm pleased to introduce our first speaker this evening, Dr. Frank Cevantos. He was raised in South Florida, was educated and trained at Harvard University, Columbia College of Physicians and Surgeons, and the Illinois Eye and Ear Infirmary. He completed a fellowship at Vanderbilt in head and neck surgery and base of skull surgery before returning to Miami to join the Department of Otolaryngology. He currently serves as co-director of the Division of Head and Neck Surgery, Sylvester Cancer Center, Department of Otolaryngology. Dr. Civantos directs the accredited fellowship in head and neck surgery, microvascular reconstruction at the University of Miami. His research has focused on minimally invasive surgical approaches in the management of head and neck cancer, and he was the principal investigator in the first multi-institutional trial on sentinel node biopsy for oral cavity cancer by a cooperative group in the United States. He continues to be active in multi-institutional trials related to sentinel node biopsy, robotic surgery for otopharyngeal cancer, and other minimally invasive approaches. Tonight, he's going to present minimally invasive techniques in head and neck surgery. Please welcome Dr. Civantos, and you are up, Dr. Civantos. Take it away.
Thank you, Ileana. Thank you, Dr. Levine, Dr. Eshraghi. It's a pleasure to speak to you all. I'll go ahead and open my presentation. Hopefully, I'll get this technology to work right. Let's see.
Dr. Civantos, I think you're currently sharing. There we go. Perfect.
So you should see now the title slide, Minimally Invasive Surgery for Head and Neck Cancer. So is everybody seeing that? Yes, okay. So this is a big topic for 15 minutes, minimally invasive surgery for head and neck cancer. So really today, all I'm going to be able to do is give you a sort of a little overview. And basically what we're going to talk about is 2 kinds of minimally invasive surgery. One addressing the neck and how to address the neck minimally invasively. And we're going to focus on oral cavity cancer for that. And then how to address the primary site minimally invasively. And we're going to use the example of oropharyngeal cancer and robotic surgery for that. But keep in mind that there's ways to address the neck for skin cancer, ways to minimally access sinus cancers that maybe Dr. Levine could talk about, and lots of other ways. And we're going to use those two paradigms as a way to sort of see how we think about minimally invasive surgery. So let's start by talking about what is unique about early and intermediate stage head and neck tumors, which are really the ones that we can think about doing a minimally invasive procedure. So number one, these are patients that have high cure rates, particularly for what is now the largest group of patients with head and neck cancer, which is no longer related to smoking, but related to the HPV virus. And these patients have a better prognosis than the historical head and neck cancer patient that was related to different mutations that were caused by smoking. And regardless of the cause of the cancer, head and neck cancer patients can have significant quality of life issues. And so any of you who have had the experience of taking care of a head and neck cancer patient or interacting with a head and neck cancer patient know that even though we have a higher cure rate in these patients with earlier or intermediate stage disease, we still deal with visible changes in appearance, difficulties with speech and swallowing, which of course all three of these can affect their social interaction. And also we can have musculoskeletal difficulties and pain, particularly neck dissection can cause shoulder pain if they get weakness of cranial nerve 11 and musculoskeletal issues. All of the above affect the ability to interact socially. The worst thing for quality of life, of course, is if we don't get it all. So whatever we do for the tumor can't change. So when we talk about minimally invasive surgery, it can never be compromising the margin. We have to completely remove the cancer. We have to have a safe margin. We don't have to have an excessive margin, but we have to know what is the minimum, and we have to make sure we don't take risks on the margins. Because the worst thing in terms of suffering is an uncontrolled cancer, which causes all the problems mentioned above, even greater than anything we could ever do surgically. What we have to do is reduce the morbidity of an approach. So if we make the exact same tumor cuts, let's say when we talk about robotic surgery, but we now have done it from the inside so that there were nothing cut to get there, we have reduced the morbidity by doing a different approach, and we've done the same tumor cuts. Similarly, if we access the same staging of the lymph nodes without having to make a cut from the length of the neck, but rather through a smaller incision, and by taking out a smaller number of lymph nodes, get the same amount of information, now we've reduced the morbidity of the approach, but now have the same information. So let me now go on to say that how we find out about these things, how do we move these things forward? Well, it's all research that has led to procedures that are oncologically effective while preserving form and function. And today I'm going to focus on two types of surgery. I'm also going to focus on two studies, okay? Really two studies that have been done and one study that is going to be done, okay? So we're going to talk about sentinel node biopsy, and we're going to talk about minimally invasive removal of primary tumors, either with endoscopic laser or with robotic surgery. We're not going to talk about transnasal skull-based surgery. We're not going to talk about photodynamic therapy. And there's even other minimally invasive procedures. And I mentioned those here, but we're going to really focus on the first two on the list. So I'm going to start by talking about sentinel lymph node biopsy, which has been perhaps the procedure that I've done the most research on. And I had the opportunity to be the PI of a national multi-institutional trial about 10 years ago. We published our results. And this was really the first study looking at this, and I'll talk about that study in a moment, but let's talk first about what sentinel node biopsy is. And what it is a procedure where we inject a tracer around the primary tumor. And today we're using mouth cancer. It's done for melanoma, as you know, and now also for squamous cell of the skin. But let's talk about skin cancer, tongue cancer for the moment. So at the bottom here on the left, you can see that this patient had an injection of a tongue cancer, and we have a marked lymph node just posterior to the jugular vein here. And that nuclear image is our first guide. And then during surgery, we make a smaller incision than we would do for a neck dissection and use a gamma probe. And this incision is a little longer than we would have needed for just this node, probably because there was another node more anteriorly, and the gamma probe is used. And you can take that lymph node out, point the gamma probe at the ceiling with the lymph node out, on it, and prove that the radioactivity that was injected at the primary site is now removed and in that lymph node. And subsequent histologic evaluation is done. And if there is a micromet, now you know that lymph node basin is at risk, and you have to do immunohistochemistry and a careful pathologic evaluation, including fine sectioning. But if you don't find a micromet, like this last slide shows, if you don't find that, now you know the entire lymph node basin is negative, and you don't have to do a neck dissection, which is standard of care otherwise. So let's talk about that for a moment. So the alternative to sentinel node is a selective neck dissection, which treats while it diagnoses. In patients with metastasis, micromets will be in the standard neck dissection field 88% of the time. You could miss them. The sentinel node won't miss them. But you don't need to stage the surgery. With sentinel node, you might have to go back in about 10% of the patients if you get a positive sentinel node. So you've picked a group where there's a high risk of the sentinel node. There's a high chance the sentinel node is going to be negative, but there's a small risk it's going to be positive. If it's positive, you might have to go back and do the neck dissection. The other side of the coin is for lesions near the midline, you'd have to do a bilateral neck dissection. So it's a complex discussion, and it's controversial. And the decision between a sentinel node versus a neck dissection for oral cavity cancer is quite complex. The one thing that is no longer permitted, and this is if there's anything I want everybody to know today, it is that you cannot do watchful waiting. So the traditional idea that you could take out the tongue cancer and just watch the lymph nodes carefully, do an ultrasound every 2 months, and if the patient gets a node, then you could operate on the neck, that is proven in randomized trial on top of multiple previous studies. And this was an excellent randomized trial published in the New England Journal of Medicine at the biggest cancer institute in India. India has the largest incidence of oral cavity cancer in the world. And in patients with lateralized oral squamous cell carcinoma, elective neck dissection had double the rate of cure of observation and therapeutic neck dissection if patients develop neck recurrences, because patients presented too advanced, and no matter how much you tried to watch patients carefully, patients would come in with disease that has extracapsular extension, and the cure rates were much less. Watchful waiting is reserved only for lesions that are either in situ or minimally invasive. Any lesion that has 2 millimeters or more of invasion, which is basically any clinical cancer, anything you look at and you know is a cancer from looking at it, that is something that needs a neck dissection. Anything that you think might be in situ, you biopsy it, it's a minimally invasive cancer, that. And so this here is the problem. So here's the problem in terms of neck dissection. So you see this lesion comes up to the midline. You can see this area is raised, so the induration comes up to the midline. This is a T1 lesion of the oral cavity. You can take this off in 10 minutes, send margins. You've resected it, so it's very tempting to say, can we watch the lymph nodes? Because to do bilateral neck dissections, which is what this patient needs, both sides of the neck are at risk, converts that 15-minute operation into now a 5-hour operation to do bilateral neck dissections. So it's not a minor decision to decide to do bilateral neck dissections because this patient's at risk of bilateral neck metastases. Yet we know from that randomized trial that this patient is at increased risk if we don't do the neck dissections. And that's where sentinel node biopsy comes in. For these early patients where we need something else between selective neck dissection and watchful waiting, which is now no longer permitted. And so selective neck, so sentinel node biopsy may be the solution to that. And I was fortunate enough to be the PI of a trial that looked at selective neck dissection, that looked at sentinel node biopsy followed by immediate completion neck dissection in 140 patients at 25 universities. And we basically were able to show a 96% correlation of the pathology. For T1 lesions, it was 100%. We never had a sentinel node miss the prediction of a negative neck dissection. For more experienced surgeons, again, it was 100%. We never had an experienced surgeon have a negative sentinel node and a positive neck dissection. And so the sentinel node technique is a very powerful technique. And because of our study and other studies and studies in Europe, there's one randomized trial in Europe that, or not one randomized trial, but one sentinel node alone trial, because of course that trial, everybody got a neck dissection. Because of the body of the literature, really, sentinel node biopsy is now an option in the NCCN guidelines. So when you see a patient with early oral cavity cancer, you can either do a neck dissection or a sentinel node. If they're elderly and you're concerned about their ability to go back for a completion neck, if they have any complication, you may prefer to do a neck. But otherwise, many of us tend to offer sentinel node for the earlier disease that's not extremely invasive. And under the new staging system, anything that's extremely deep is a T3 lesion, you know, if it's over 6 millimeters deep. So we are really picking early patients for sentinel node. But an important thing to point out is there's never been a direct comparison of these two techniques. And that's the final point I want to make about sentinel node is we are currently doing a randomized trial through the NRG, and Stephen Lai from MD Anderson is the PI of this trial. I'm on the quality assurance committee of this trial. And we're basically randomizing patients to receive either sentinel node or elective neck dissection. There's quality of life endpoints, as well as the primary endpoint of survival and recurrence in the neck. And there's some other parts to the study where we're looking at how PET predicts neck involvement and things like that. But the main thing is this study will really delineate more completely the role of sentinel node, which at this moment remains, you know, a hotly debated topic. So that's a minimally invasive approach to the neck and an alternative to patients that are concerned about the possible shoulder weakness and other musculoskeletal things that can occur even with a selective neck dissection. We no longer do radical necks for anything but massive tumors, you know, so the radical neck has gone by the wayside. We always preserve cranial nerve 11, but even with preservation of the nerve, the manipulation of the nerve can lead to musculoskeletal problems and a shoulder syndrome, and that's what a sentinel node can avoid. So I'd now like to talk about a minimally invasive surgery to the primary study. And I'd like to contrast laser surgery with robotic surgery. So endoscopic laser surgery. So here you see in a very narrow field through a laryngoscope, a small radiation failure tumor of the anterior larynx. And with a laser, you can, usually we cut this tumor in half, take it out piecemeal, and with a laser, you remove it, put in a keel to prevent web formation. And this is the traditional minimally invasive primary surgery. But the problem is, you know, you're in a very narrow field. You can't see the whole tumor at once through that little tube. And especially where we have wider exposure higher up in the oropharynx. But now with the new SP robot, which is now acquiring, we can even go into the larynx now with a very tiny robot called the SP that the Intuitive Corporation has. And I'm, by the way, I didn't declare my conflicts of interest, but I have none and I receive no funding from Intuitive. There's some advantages to robotics over transoral laser surgery, which are the limited exposure of the laryngoscope, the distance from the surgical field. You know, with the robot, you have a telescope that goes right in to where you're working, and you have hands that go into the throat and work right where you're working. You're not working with a 15 centimeter or 12 centimeter instrument. So you don't have a long instrument that increases your tremor. You have 3D view. You're not, you know, you don't have a reduced depth of perception because you're working from far away, and you have a motion scale, so you're magnified, and when you move a millimeter, so there's motion scaling. So you seem on your field, it seems like you're moving a much larger distance, and you're actually only moving a millimeter, but you see it as an inch, so all of that helps the surgeon to get more control of his instrument. So that's the advantage of the surgical robot, which at this point, Da Vinci is the main robotic system, although there are competitors. This was originally developed in '85, and we have the SI and the XI, and now the new SP, which is specifically designed with transoral ENT surgery in mind. The index disease has been oropharyngeal cancer. Now with the SP, we can start to move farther down to the larynx and hypopharynx. And it's really the epidemic of oropharyngeal cancer that I think drove robotic surgery, because with the HPV-related oropharyngeal cancer, we've seen an exponential rise, as you see on the graph at the bottom. And when detected early enough, surgery offers significant reduction in morbidity relative to chemoradiation. And allows de-escalation of chemoradiation. And that's now proven in a trial, ECOG 3311, which I'm going to talk about in a moment. But again, the benefits of the robot: no line of sight issues, 3D visualization, great degrees of mobility because the robot turns more than a human wrist can, motion scaling, tremor filtration. It's a cutting edge surgery that provides tissue that accurately stages the patient. So now they can go to chemoradiation really truly knowing if there's aggressive features, how many lymph nodes are involved, et cetera. So this is Dr. Giovanna Thomas and myself 11 years ago when we performed what we believe to be the first transoral robotic surgery in Florida, and for sure the first transoral robotic surgery in South Florida. This is with the SI robot, and you can see the surgeon sits actually away from the patient and controls the robotic arms, and the assistant sits at the head of the patient over here on the left lower area and actually suctions and retracts and makes sure the arms aren't hitting the teeth. And you can see with these robots, and I don't have time to show you a video of the SP, which what I have loved to do, but you can see with these robotic arms, you bring in 3 arms into the mouth, and with the SP, it all comes out of a little tiny tube. So it's a totally different thing. And that will be another talk in and of itself. But I thought the history would be fun. So it's only 11 years since we started doing this. I mentioned ECOG 3311. The important group here is in the middle, the intermediate risk, where we proved that with intermediate risk patients, we could de-escalate safely with equal results, going from 60 to 50 gray, and better functional outcomes. And so patients in that intermediate group were randomized. Otherwise, it was an observational trial for the other groups, but the results basically were that for P16 oral cavity cancer T1, T2, surgery was safe with good oncologic outcomes and allowed for de-intensification. For low-risk disease, you could do surgery alone with a good progression-free survival at 2 years, not giving any postoperative radiation. That was for low-risk disease, meaning 1 node or less, and no high-risk features. For those with intermediate disease, meaning less than 5 nodes, less than 1 millimeter extranodal extension, and reduced, those were less than 5 nodes and less than 1 millimeter ENE and uninvolved surgical margins, you could reduce the radiation and had better function and equivalent survival. Basically, that regimen of transoral surgery plus 50 gray is going to need to be the working treatment plan for that type of patient going forward, and can be compared to optimal non-surgical therapy in subsequent trials. So in conclusion, this is my last slide. In appropriate patients, and by the way, we were one of the largest accruers to the ECOG 3311, and my partner, Dr. Thomas, was a co-author on that paper. So in appropriate patients, morbid surgical dissections for lymph node removal can be avoided using sentinel node biopsy. This is standard of care for melanoma and an option in oral cancer and cutaneous squamous cell cancer. And our currently ongoing randomized trial will define really the role of sentinel node biopsy relative to selective neck dissection for oral cancer. Minimally invasive approaches to tumors of the pharynx involve a combination of specialized scopes lasers, and robots. And a recently completed trial has established that robotic surgery is an excellent alternative, allowing de-escalation of adjuvant therapy for appropriately selected patients, though obviously further work is necessary to delineate exactly where to put surgery in the armamentarium relative to chemoradiation. And that's it. That's all I've got. And I thank you all, and I'll stop sharing.
Thank you, Dr. Civantos. And before we get to our first poll question, I remind our participants that you have a very unique opportunity tonight to reach out to our experts and ask them questions. Dr. Civantos is actually going to be the moderator for that Q&A session and tee them up for himself and his other colleagues. So please enter your questions in the Q&A feature button at the bottom of your Zoom screen. And now let's get ready for our first poll question. Let's put that up, Luciano, and that is that a 65-year-old man with no major comorbidities presents with a cancer just off the midline anterior tongue, 1 centimeter by 1.3 centimeter, and indurated and invasive on physical examination. Appropriate alternatives for initial management would include the following. A, primary surgical management, including partial glossectomy and bilateral selective neck dissection. B, primary radiation therapy only. C, primary surgical management, including partial glossectomy and sentinel node biopsies. D, primary surgical management, including partial glossectomy with watchful waiting observation of the lymphatic basins, no primary neck surgery. E, A and C are the preferred appropriate options, or F, all of the above. Now, see how our registrants and our participants see this. And Dr. Civantos, let's see how well they do in this poll question as soon as we get the results. They're being tabulated as people enter.
Let's see how well I did. Hopefully
That's right.
That.
Okay, what do you think?
That's good. At least B got 0, so that was good.
Okay. Is E with the A and C preferred appropriate options the right way to go? The right answer?
Yes.
Well,
So
they did very well.
So some picked A, some picked C. Those are both reasonable options. A and C are both reasonable options. D, watchful waiting, should never be done.
Okay, very good. Then we will continue on with Dr. Corinna Levine, who is our next speaker before Dr. Civantos later on moderates the Q&A session. So Dr. Levine is an assistant professor at the University of Miami in the Division of Rhinology and Anterior Skull Base Surgery. She completed her medical training at Yale School of Medicine and went on to a 7-year otolaryngology residency at the University of Washington with an infolded outcomes research fellowship and MPH. She completed fellowship in rhinology and endoscopic skull base surgery at the University of Miami. Dr. Levine joined the faculty as a surgeon scientist, and her clinical practice focuses exclusively on chronic sinusitis and endoscopic skull base surgery for benign and malignant sinonasal and orbital tumors and repair of skull defects. Dr. Levine is a director of clinical rhinology research and is the recipient of several grants, including the Triological Society Career Development Award and the University of Miami KL2 Career Development Award. Her research focuses on improving CRS outcomes through precision medicine approaches to care and addressing CRS health disparities. Dr. Levine continues to be committed to education and teaching as the director of the Rhinology Resident Rotation and through clinical education of Rhinology Fellows. She's also a member of multiple national committees, including the American Rhinologic Society Research and Mentoring Committees, the North American Skull Base Health Value Committee, and the American Academy of Otolaryngology Skull Base Committee. Please join me in welcoming Dr. Levine. It's all yours, Doctor.
Great. So I think everybody can see my presentation. I'm just going to get started here. This is going to be a presentation on clinical rhinology research and some skull-based care advances. And I have no disclosures. We are going to talk a little bit about some of the research that I've done as part of my grant, so I listed it here. So the objectives for my talk for you guys today, I want to share some of the exciting rhinology research advances that we've been able to do in some of our research, particularly related to social determinants of health. And also I want to share some of our endoscopic skull-based surgical advances. We've had a bunch, but I'll focus today on really a skull-based resection and reconstruction advance that I think was a nice thing for us to be able to offer our patients. So talking first about rhinology research and chronic rhinosinusitis or CRS. One of the things that I think we pride ourselves in is that South Florida has a very diverse population, both racial and ethnic, cultural, economic, and this is the 2010 census. I think the new data will be coming out soon for 2020 and 2021, but we really have a good diversity of Hispanic patients, as well as non-Hispanic Black patients and non-Hispanic white patients, and a really nice group of kind of cultural kind of milieu of a bunch of different types of people coming together. And then of course we have our wonderful international colleagues and friends who come visit us. So that's one of the great things about being here, but it also means that this is an area where we can really do some research in some of these differences. So with the chronic rhinosinusitis surgery population at the University of Miami is also very diverse and probably one of the most diverse in the country. This is the demographics of our surgical patients recently. And you can see again reflected, we have about 40% of our patients are Hispanic. We have a large number of non-Hispanic patients, about 20% of our patients are Black. And so we do have a nice variety of patients. And one thing that happened was when I came here as a fellow and stayed on as an attending, I observed some differences in our Hispanic versus our non-Hispanic patients as far as the presentation of their disease. And in particular, the observations were they really had worse quality of life when they presented. They had more severe disease for their chronic sinusitis, and they had a longer duration of disease. And one of the things that I wanted to do as an epidemiologist and somebody who looks at outcomes research is to really study that. So we did an objective prospective cohort study comparing these two groups. So this is a cohort study. And what we wanted to look at as our outcome is quality of life. And in rhinology, we all have a sense of humor. So all of our instruments for disease-specific quality of life have names. This is the SNOT-22, which is chronic rhinosinusitis quality of life. And I'll refer to it as quality of life for the rest of this presentation. And what we did was we included patients who had more than one sinus involved. We have 10 different sinuses, so we wanted people with a decent amount of disease that were having their first sinus surgery. So this was the first time they were undergoing surgery. They had filled out the preoperative quality of life information and they had self-reported their ethnicity to us. And we excluded anybody who we thought would have a disease in addition to this that might impact their outcomes, like radiation or immunodeficiency, something like that. And so I'm just going to present a little bit of our data because I think it's pretty interesting and helps us think about where we want to go. So these are our Hispanic and non-Hispanic cohorts. You can see that they're pretty similar in their age, gender distribution, race distribution. And here what you can see is obviously the difference that's not surprising in preferred language, where about 55% of our Hispanic patients prefer to speak Spanish. And this is not surprising for anybody who's a clinician here. We then looked at our outcomes as far as our quality of life. And this is really where I think that we find some interesting things. So the quality of life is on a scale of 0 to 110. Higher score means worse quality of life, and a clinically important difference is 9 points. That's where somebody would notice it in their day-to-day life. So before surgery, pre-op quality of life, 55 in our Hispanic patients and 37 in our non-Hispanic patients. So this is a really big difference. And these are people who are presenting with similar amounts of disease, similar comorbidities, and yet they have significantly different quality of life that they're reporting, much worse than our Hispanic patients. And what I'm happy to say is that at least after surgery, we see that difference go away. So 3 months later, after they've healed from their sinus surgery, we see that those numbers are pretty much the same. But this is a big difference. And this is a number that is both statistically and clinically significant, which means that Hispanic patients really do have worse quality of life when they present to us. And so then the question is, why? What do you think? Well, we want to understand the etiology behind that difference. And so the first thing we want to think about are social determinants of health. It's a great place to study social determinants of health. You're thinking about things like education, economics, the cultural experience, insurance access, etc. But also other things like disease severity. Are they just presenting with worse disease? Or is their care delayed, meaning that they just really haven't been able to get the right care as fast? So we looked at all of these things in the same group, and I'll show a small set of that data. So here you can see our self-reported outcome from our patients. This is household outcome. And there is a notable difference between our Hispanic patients and our non-Hispanic patients, with our Hispanic patients having a generally lower outcome, although not everybody. Highest education, also again, more patients in our Hispanic group had only a high school education as opposed to college or graduate degrees that they reported to us. And so we see these differences in the language that I've already discussed, in income, and in education. And so we wanted to know if that explains the quality of life difference. And when we did our analysis, we wanted to look at the correlation with quality of life. And what we're seeing is that this is really a weak correlation. So it maybe explains a portion of this, but it is certainly not the reason for all of the differences in quality of life that we're seeing. So we need to look for other reasons why this might be happening. So then we looked at disease severity. And so this is a little bit of a busy slide, and I'm going to explain. So if you look where I'm highlighting, we have CT scan score and number of sinuses involved in disease. CT scan scores, the 9.4 and the 10.2 are pretty similar between the two groups. And the number of sinuses involved is also pretty similar. So what this tells us is that these patients have pretty similar amounts of disease. Maybe the Hispanic patients have slightly less disease than our non-Hispanic patients. But what we're looking at is features that are not captured in these disease severity scores that are widely used. So one of those things is polyps, another is bone growth, which happens in response to chronic inflammation or chronic swelling over time. And we see that in a lot of our patients. It's also called neosteogenesis. That they needed advanced surgery, so surgery where we needed to drill or do extended procedures, or that they have signs that they're on that Th2 pathway, meaning that their eosinophils are high within their tissue. And what we did is relative risk. So we compared the Hispanic and the non-Hispanic patients using our non-Hispanic patients as the reference group. So RR is relative risk. And you can see that the relative risk for all of Hispanic patients in each of these areas is higher, meaning it's above 1. Their probability of having whatever it is that we're looking at is higher in each of these groups. But it was statistically significant in the presence of polyps, which means that the probability of a Hispanic patient having polyps is 2.5 times greater than a non-Hispanic patient. So this is a significant difference, and it's a notable difference in disease presentation. And we know that polyps are associated with worse disease and also worse outcomes. We also looked at care delays. Remember that I had said that patients reported longer symptoms. And so we asked a bunch of questions of our patients about how long they had had their symptoms and what type of care they got. So we asked if they had at least 3 primary care visits without symptom improvement. And about 60% of our Hispanic patients said, yes, that's actually what has happened to them. And they had gone back and not gotten an improvement. And when we asked about the duration of their symptoms, they told us that also about 54% had had more than 3 years worth of symptoms. So this is a long time and was higher than our non-Hispanic patient population, although I would argue that everybody had too long of a duration of symptoms when you look at this. And we also see that our Hispanic patients were less likely to have already seen an ENT before they got to us as compared to our non-Hispanic patients. So these aren't powered numbers like the first set of numbers I showed you, but they do tell us that there's a trend here that we need to investigate further. So the conclusions and the take home from this information is that our Hispanics do have worse quality of life at disease presentation when they first come to us and they first get treated. And social determinants of health, but also differences in disease severity that aren't picked up in our standard scoring systems and longer duration of disease are likely areas as to why this is happening. So how do we use this information? Well, of course, it's motivation for further investigation and further research, but clinically, I think one way that we can use this is with care adjustments for social determinants of health. So you really want to be thinking about how you can tailor your discussion with your patients to make sure that they are really understanding and engaged in their care, that you're being thoughtful about any language barriers, that you're giving them the opportunity to have all their educational materials in their home language, whether that's Spanish or English or Creole, and that we really are asking questions to make sure that they understand what's going on. Also, our surgical plans need to be adjusted for some of these disease severity measures that we're seeing that aren't captured. And Also, we want to raise awareness of chronic sinusitis, because when patients aren't improving, we're hoping that we can get our primary cares and some of our other early providers who are the first to see these patients to start investigating for that earlier so that they're caught early. So now I'm going to very quickly move on to, with the last couple of minutes, the endoscopic skull-based surgical advances. And so sinus and anterior skull-based neoplasms really present often in late stages because people don't notice them until they start having problems. And one thing that we see is that a lot of times they will contact or invade the lamina poplacea, which is that thin bone on the medial side of the orbit near the nose, or the periorbita, which is the tissue that surrounds the orbit, or even the orbit itself. And so you can see that in this image and where I've highlighted in purple. And frank orbital invasion obviously needs to be treated with a resection. So if it's right inside the eye, you need to remove it. If it's right on the eye and kind of on the edge, effective radiation or radiation is an effective area of local control for kind of gross orbital disease. But we know that even if it's not totally covering that whole orbit, it can cause some orbital and optic nerve toxicity and often can lead to blindness and vision loss. So one of the problems is that we sometimes have patients who have intact vision, like the CT scan of the patient I just showed you on the other slide. So they have a functional vision, but they have lamina or periorbital involvement. And so what we really want to do is we want to remove that gross disease, but we want to reduce the amount of orbit radiation so we can preserve their vision. So one of the things that we have been doing, and I say we as the Rhinology and skull-based division, we've been doing endoscopic resection of the periorbita and the anterior skull base. And then we've been doing our usual reconstruction, but also covering the eye to hold in now the exposed orbital fat. And I wanted to just show a little bit about what that is. So this is a schematic showing us what an anterior skull-based resection is, which is resecting from the frontal sinus to the sphenoid sinus and between the eyes. And I've highlighted here in this red-pink color that now what we're also doing is taking out the lamina and we're taking out the periorbita, so we're exposing the orbital fat in those tumors that are contacting that area. And then we do a reconstruction, and that reconstruction is then the usual reconstruction we would do in the anterior skull base, but it also drapes over the orbit and covers up that area of fat that is now exposed so that we cover that area in the medial aspect of the orbit, and so that it's not having all the fat spilling out into the sinuses. So this is a quick video of just kind of looking at the exposed skull base. And what I'll point out is that here is your floating skull-based tumor. All of this under here is the dura, and then under that will be the brain. And then over here is your periorbita that has been involved with the tumor. And you'll see that we're going to be trying to resect that. So this is a very quick video that just shows you that now we're pushing over that periorbita, we're drilling down some of the bone, and now we're removing some of the dura so that this way we can really get out the tumor. And you can see the exposed brain in the background, but also here, now we're removing all of this thick periorbita off of the eye, and that will allow us to expose the fat. And as long as we have nice, healthy fat, we send down some margins from that fat to make sure that we've really cleared the disease. And then once we do that, to reconstruct that area, we need to reconstruct the skull base, but we also need to reconstruct the eye. So you can see that this is a nice reconstruction with alloderm, and this heals really well, and patients go on to be able to tolerate radiation. So this is one area that we've been really happy with how this has gone. And we've actually had a series, and I went back and looked at some of our numbers. We've done this in about 9 patients. We've had negative margins in just under half of them. So some of these patients did end up getting more radiation to their eye than we wanted. But we were able to reduce postoperative radiation to the orbit in almost all of them. And all of these patients had their vision intact after the surgery, but really what we care about is their vision intact after they get their radiation treatment. And for the majority of these patients, it is intact, or they are able to maintain some functional vision. So that's really great. And they also have good extraocular motion after radiation. We are reconstructing a whole wall of the orbit. So we do want to look at eye position. About 22% had axamos. And again, it's a small series, it's only 9 patients, but we did see that there's also some significant quality and life improvement, remembering that 9 is the number that you want to hit for something that people notice, and here it's more than double that. So certainly this has made a big difference for a lot of patients, and I think the quality of life difference is meaningful. So the target population here is really patients with intact orbital function. and that have lamina or periorbital tumor involvement. And the technique is, again, the endoscopic resection of the periorbita and some of that orbital fat with our anterior skull-based resection that we do endoscopically. So this way, again, everything's done through the nose, there are no incisions in the face, and people recover a lot faster. So this is a safe and promising method to remove some of this burst disease and preserve vision after multimodality treatment. We're hoping to follow these patients out longer to see how they do long-term. So take-home points from this. The first section, we talked a little bit about our Hispanic patients and that they have worse quality of life at disease presentation. And we went through a few of the things that could be related to that, the social determinants of health, the disease severity, and the longer duration of disease. And we also talked a little bit about this new technique that we have to preserve vision, resecting or using the periorbital resection. And then we talked about patients who have intact vision and anterior skull-based tumors as really the target population for this. So these are patients who could be resected endoscopically. And we want to reduce radiation to the orbit so that we can improve the long-term vision and quality of life. So I want to acknowledge that all the things that I present are part of a team effort. And I want to just mention Roy Cassiano and Zuba Sarji, who are other members of the skull-based and Rhinology division who've really helped with everything. My email's there if you have questions for me.
Thank you very much, Dr. Levine. And before we introduce our final panelist, let's get on to our second poll question, which we will put up now. And that is, what differences did we find between the Hispanic and non-Hispanic patients with medically refractory CRS disease? A, more severe disease. B, worse quality of life and more severe disease. C, worse quality of life. D, worse disease outcomes. And now let's give our participants a few seconds to get some answers. And Dr. Levine, you can make some comments on the results. So remember, you still have that Q&A button at the bottom of your Zoom screen. If any of you out there listening to your colleagues tonight would like to enter some questions and have them answer you directly. And there it is, Dr. Levine. How'd they do?
I think they did pretty well. So it is true that they definitely have worse quality of life, and we see some signs of worse and more severe disease.
Okay, so obviously they're paying attention. Thank you very much, Dr. Levine. And now let's get to our final speaker of the evening, Dr. Adrien Eshraghi, who is a surgeon scientist with over 150 scientific papers published, focused mainly on cochlear implant surgery and various hearing disorders. Dr. Eshraghi serves as co-director of UHealth Ear Institute, has a busy clinical practice, and is conducting various clinical trials in patients with hearing loss. Dr. Eshraghi directs the University of Miami Hearing Research Laboratory and is investigating, developing, and testing novel autoprotective therapies. He serves as academic editor of various scientific journals and is enthusiastically involved in mentoring international scholars, both in his clinics and in translational laboratory. Please welcome Dr. Eshraghi. Take it away. Dr. Eshraghi, are you there with us? Maybe you need to unmute.
Thank you, Dana. Sorry, I have to unmute myself. But actually it's good to see when someone is deaf who cannot hear, what's the experience from people who can not hear us. So it's my pleasure to share with you the research and the clinical work that we are doing in regard of cochlear implant surgery. The story of cochlear implant surgery started 74 years ago in an operating room in Paris, when Arias, who was an otolaryngologist, was doing a surgery, ear surgery, on a patient who was deaf, but also has a facial paralysis. Patient had a cholecystioma, a very invasive one. And the journal was an electrophysiologist who developed an electrode stimulator to stimulate the facial nerve. So Arias tried to stimulate the facial nerve of this patient that was having a surgery under local anesthesia, and the patient started to hear. And from that point, Arias oriented his research, not only doing research to stimulate the muscle, but also trying to see how we can help the hearing of the patient. So both together made their first CI that you can see on the right side, but unfortunately there was a lot of problem with the biocompatibility and rejection of the device, and they stopped the research after a few years. But then a few years after, in LA, a patient brought the paper that was published in France in French to William House, asking about this cochlear implant. And Dr. House became intrigued and started research with Doyle. And they started their first cochlear implant in Los Angeles. And then he continued that with Urban, who was a biomedical engineer. And they commercialized the first single electrode cochlear implant. But then in San Francisco, Michelson and Merzenik started to work on multi-channel electrode on animal studies. And the debate started between people who think that we should have multiple electrode or one electrode. Finally, in France, Chouard, who was the student of Arias, start to implant the first multi-channel electrode. Chouard was actually one of my professors when I was in France. And that multi-channel electrode had some challenges because the approach was using a middle fossa approach that was very traumatic. And despite the fact that it was the first multi-channel electrode that was implanted, did not stay long time in the market. And then in 78, the Billiard report finally established the superiority of the multi-channel electrode over the monochannel electrode and the fact that the patient who are deaf can benefit from cochlear implantation. And that started a significant advances that follow in the field of cochlear implant surgery. So here you can see the picture of Juno and Arias, and you can see here the William House picture. And here is a contribution of various teams around the world. 4 teams really impacted the history of cochlear implant, and you have them in red. I want to say 5 because we have 5. The 3M of William House stay monochannel and was not able to follow the competition with the other ones. But the multi-channel of the San Francisco ended up to give Advanced Bionic that is now commercialized by the United States. The work of the Arias and Juno ended up to become a Neurolec and MXM, and now it was bought by Oticon and is in clinical trial in the US, but is used significantly in Europe and North Africa. And the work of European Hochmar and Desoyer ended up to become a medal that is from Europe. And in Melbourne, in Australia, the Cochlear Corporation also was successful to have a multi-channel electrode. So if you want to know more about this work, you can always look at the paper that we published a few years ago in regard of this history that was very exciting and interesting. So what causes hearing loss? Obviously genetic, possible infection, noise trauma, drugs, cisplatin, antibiotic like aminoglycoside, high dose of diuretic. And what we're going to talk about now is really what happened in the inner ear. So just to remind us, because I think we have a diverse practitioner in our audience, that if we have a sudden sensorineural hearing loss, we can treat the patient in the first acute phase within 6 weeks by oral or intratympanic steroid. If you have a chronic progressive hearing loss, patient can benefit from hearing aid. But once the hearing aid is not able to help us, then we have to think about something different, and cochlear implant is now the best option. So what's cochlear implant made of? We have two parts. We have the internal device that you can see here in A that's implanted below the skin, and the electrode is introduced in the cochlea to stimulate the ganglion cells and the auditory nerve. And we have an external part of the device, the number B, that is going to be outside, and we're going to see how it functions. If you want to know more about that, we published this paper that explained the biomedical engineering of principle of the modern cochlear implant and what are the recent surgical innovation. So just to summarize, in short, that the external part of the device has a microphone, and the sound is processed by this external device, and through a radio transmission through the skin is transferred to the internal part device, and the internal device gonna stimulate an electrode that is inserted in the cochlea very gently, and this stimulation gonna help to transform an auditory information first to electrical information, and then transmit to the nerve, to the brain. So now that we know how it works, let's see who are the candidates. We have two categories of patients, the children and the adults. Let's talk about the children. 2 to 17-year-old patient with severe to profound hearing loss can benefit definitely from cochlear implant. We have to remember that this patient, if they have difficulty to hear, they should have a hearing aid right away to help them. But once the hearing aid doesn't help them enough, then we should not hesitate to have an appropriate evaluation by a team that specializes in pediatric cochlear implant to offer them the CI. But if patient has a congenital hearing loss, we should not wait too long. We can offer that to kids very young, 9 to 24 months, with the profound hearing loss. And now, fortunately, because we have universal screening in multiple places around the world through the acoustic emissions in the ICU or in the pediatric unit when the kids are born, we can detect children who are at risk of congenital hearing loss. And once they're detected, we should confirm that with the ABR and process to have a cochlear implant evaluation. How about the adult? Adults are also candidate when the hearing aid is not anymore helpful. This is to remind us that this is the level of loudness of the sound, and this is the different frequency. And as you can see, once we have a moderate hearing loss, already we have difficulty to hear during the conversation. You can imagine what can be the trauma caused by an airplane or a truck to the ear. Nevertheless, once we know that someone has this type of hearing loss that is around severe to profound hearing loss, we need to think about what we can offer them that's going to be better than the hearing aid, because the hearing aid is not always helpful. Hearing aids sometimes amplify a sound that is not really easy to be understandable by the patient. If the patient has a very poor speech discrimination, a hearing aid just going to amplify very bad sound, and therefore the patient cannot benefit from that. And imagine that in the background noise, it becomes even worse. So what's the outcome? When we look at the outcome overall, 80% of the adult can use the phone. 90% of the kids attend the mainstream school. When someone becomes deaf, we should remember shorter duration of deafness, better outcome. Postlingual adult, really very good outcome. Early kids, less than 2-year-old, very good outcome. If the kid is more than 5-year-old and was congenitally deaf, it's very difficult to develop the speech after 5-year-old. So it's going to be very challenging. So earlier you do that is very important. So I want to say 4 or 5-year-old is really critical time, because if you don't hear, you cannot develop the language in your brain, and that's going to be significantly impacting your life, quality of life in the future. So when we look at here, the result without hearing aid here is in pink, and in blue we have the cochlear implant. You can see how much we get improvement with the cochlear implant. And look what happened with the sentence in noise. When you have background noise, hearing aid is really very, very poor. You cannot get anything, but cochlear implant still can help you. So what happened with the kids? Kids can develop the language, they can develop their auditory skills, and it helps also the cognitive performance. How about the adult? Obviously, cochlear implant is going to be very significant to help them for safety, for autonomy, caring for the family, for the kids, the baby that's cry, can help them to not be depressed. Imagine a grandfather cannot communicate with their grandkids, and also cannot transmit all of the life experience to their family. And finally, what is very interesting, always they ask us, what is the quality of sound? Obviously, this quality of sound is a little bit different at the beginning, but the brain plasticity can help us to manage that the brain can understand that. So I'm going to have to give you an example of what is the way that they hear.
Do you like camping?
Do you like camping?
You see, it's a little bit like a Mickey Mouse sound.
Do you like camping?
Do you like camping?
But then over time, the brain can slowly integrate and
Do you like camping?
Do you like camping?
Do you like camping?
So let's talk about the quality of life. Various measures of quality of life have shown that cochlear implant is really significant to improve the quality of life. So the cost is worth for the society and for the individual to have this device offered to our patient. So Complication, they are now minor. I remember when we started with these surgeries maybe 20 years ago, there was some issue with the skin. We are afraid that the skin gonna open or infection. We don't see that anymore. The rate of device failure is below 2%. So really, when we think about it, the risk is very minimal compared to the benefit for the patients. So now let's talk about something more interesting. This device now is seeing an expansion of its indication. So single-sided deafness, for a long time, we offered to the patient a cross hearing aid. You know, the head gonna make shadow to the sound if the sound comes from the other side. So a cross hearing aid was helping to help to hear from the side that we are not hearing. But now cochlear implants have shown with multiple studies that can help the patient to overcome this challenge. And we know that the benefit is multiple. Patient have better speech perception with noise, quality of life is improved, sound localization is improved. If patient has a tinnitus, when you have hearing loss, you might have a lot of tinnitus, noise in you. So cochlear implant can be actually very good to overcome those tinnitus. So the kids, you know, for a long time, you know, the young kids were a little bit concerned about the health issue. Are we going to go for surgery or not? But now we know that if it's the kids, really, we have the proof that the patients, the baby doesn't hear because of genetic testing, because of the ABR, because of history, family history. Then once we have the confirmation, we can do the surgery at 6 months, 7 months, 8 months. Anesthesia below 6 months might be a concern when the kids are very young. But this is a surgery that can be done in 1 hour and a half. So we can do that surgery for kids less than 1 year old now. So let's talk about other type of issues. Patient with dual diagnosis, patient with Usher syndrome. Usher syndrome is a very, very challenging syndrome, as you know. Patients can have hearing loss, visual impairment. There is 3 types of Usher syndrome, 1, 2, and 3. And I'm going to focus on the Usher 1 because Usher 1 is patient with congenital hearing loss. And when the kids become older, then 5, 6, 7, I have few of these patients, 8, 9, or 10, they start to slowly lose their vision too. Imagine you cannot hear, you cannot see. Catastrophic. So if these patients are not implanted early on, it's too late because this individual cannot have anymore the benefit of cochlear implantation if they didn't have the equipment early on. So let's talk about Usher 2 or 3. Those patients have maybe hearing loss gradually over time, but they can also benefit at certain point from cochlear implant. So it's good to monitor them, give the hearing aid to them, and the right time when the hearing aid is not helping them enough, switch to go for cochlear implantation, because when the blindness happen at adult age, these patients need to be able at least to hear. When we talk about Usher 1, remember those patients can have also imbalance, and that's can be very challenging for them. If you want to know more about that, you can look at this paper we published recently about the outcome of the cochlear implant in Usher syndrome. So now let's talk about another diagnosis. You know, children with autism are very common in our practice now. 1 out of 54, incidence is 1 out of 54 per CDC. There is an increasing rate of autism everywhere in the world. So when patients have autism and hearing loss, imagine the challenges. So we are one of the first centers who studies our outcome. And I can tell you that many of these patients benefit significantly from cochlear implant. While at the beginning, a few publications was mentioning that, oh, kids have autism, they are implanted, they start to have more behavior issue. That was because those kids just become older. And when you become older and you start to hear, then you become more aware of also of your challenges, then you can have more behavior issue. So, but we find out in our patients, in our studies, that the benefit of CI is significant. Remember, the benefit is not only the fact that a kid is implanted and can talk, because we have receptive speech and we have expressive speech. Receptive speech is to hear, expressive to talk. So we know that many kids with autism cannot talk, and at least 25 to 30% of the individual with autism who do not have any hearing loss cannot talk, because that's the nature of the autism. So if a kid is implanted and is not talking, that doesn't mean that the kid is not getting benefit from the implantation, because many of them become aware of their sound, of the environment with the interaction with their family, so they can change completely their family. But if a kid is implanted early on and is not improving enough, always think about maybe the kids have other disabilities, other issues such as autism. So when we do the counseling with the parent, we have also to have the right expectation. The parent should know that the kids might not develop as good the speech as a neurotypical kid. It's going to help them, but it's not going to be the same way that they're going to develop the speech. And maybe they're not going to talk because that's the nature of the autism. So the appropriate expectation is something that we need to have in the multidisciplinary manner in our team. So we have actually, for all of these kids, a group of psychologists, educator, social worker, audiologist, obviously, and surgeon, and we discuss each case individually to see what's the best way to go. So if you want to more about that, we have this publication that was a reference for implantation of kids with the autism with the cochlear implantation, and you can look into that in PubMed. So we talk about hearing loss, mainly about peripheral hearing loss so far, but remember, it's not only peripheral hearing loss that's an issue. Some people, some individual cannot hear, not because only their hair cells, their inner ear is not working, but maybe there is also a problem with the central auditory processing. The sound gets to the brain, but the brain is not processing it. And that's actually the case of many kids with autism, that if they don't improve well, because the sound goes to the brain, but the brain doesn't process it well. So in my lab, we do obviously a lot of work on cochlear implantation, but also we try to understand better the issue of the central auditory processing in our patients, and we are doing extensive research on that area. And that resulted actually to publication of a recent book about gut-brain connection, myth or reality, that the book just came out. And I invite you to look into that book that discuss actually the effects of the microbiome in overall our health. And it discusses various issues such as autism, such as auditory processing disorders, such as Alzheimer's disease, such as various types of cancer, or such as Parkinson's disease, and even accelerated aging. So this book was done by the help of many experts around the world, and we are happy to share with you the publication of the book just last week. So let's talk about now about the adult, the elderly. We were actually one of the first groups to publish the cochlear implantation in patients more than 8-year-old. There was a lot of concern about processing at that age. The fact that maybe they're going to use appropriately their hand. We showed that in our group of more than 80-year-old, those patients benefit significantly from cochlear implantation. So if you want to know more about that, you also can look at our paper that was published, and we share that with our patients to reassure them that they can go forward with the surgery. So I'm not going to expand on other type of device than cochlear implant, but I just want to remind you that if the patient is not a candidate for cochlear implantation, there is other devices that can help them to overcome their hearing difficulty, but we're not going to discuss them tonight. And University of Miami Institute is offering all of these new devices like Osia, Bone Bridge, Baha, and patient can, if they are not candidate for cochlear implantation, they can maybe benefit from those devices. So let's talk about another issue that's very dear to me and my team, because we work on seeing how we can protect the residual hearing. Once you put the cochlear implant electrode to the cochlea, if the patient already have some hearing, they can lose that. So we studied on our patient, and we find out that we can preserve 41% for 41% of the patients, this residual hearing. Preserving the residual hearing is important. Why? Because if the device is off, patient can still have the safety of having some sound awareness. If patient is in the shower, the device is not with them, they can still hear the alarm if something going on, the fire alarm or something like that. And we know also that many of these patients are going to maybe need another device in the future. So if we preserve the residual hearing and the inner ear, then the second implant might work still better. And also we are looking at a lot of progress in medicine. Who knows, we're going to do regeneration of hair cells and inner ear. So it's good to preserve as much as possible the residual hearing. So one area that is new is also the new device that we call them electroacoustic stimulation. These are new cochlear implants that have two components. So they use a hearing aid for the frequencies that still there is some residual hearing, and they use the electrical stimulation for the high frequency that are not there. So to be able to use this of device in the future, we obviously need to preserve the low frequency residual hearing. So we are doing a lot of work in my lab actually to see how we can understand better what's happened that patients lose their residual hearing. We look at the various mechanisms involved. And just to summarize, one area is the macroscopic damage. As you can see, the electrode in the cochlea can cause damage significant in the cochlea. But if you don't have the macroscopic damage, you still can have some residual, I want to say, microscopic damage that cause inflammation and foreign body reaction to the inner ear, and those inflammation and fibrosis can make you lose the rest of your residual hearing. So we tried in my lab to develop a 4-stage of first screening in vitro candidate drugs, then doing ex vivo to test those drugs in the model of cochlear implant in a P3 rat. And then if that worked well, then we do animal surgeries, and we look at the animal model of cochlear implant with guinea pig to see if the drug that we are testing can protect the residual hearing with or without electrical stimulation. And finally, if these 2 stages are positive, then we go to the clinical trial. And we have multiple drugs so far that were tested in my lab. We work with them, and many of them now arriving in the clinical trial, and we hope to be able to help our patients soon. So in conclusion, cochlear implantation is a safe procedure in 2021 that provides large benefit to our patients, both kids and adults. The indication of cochlear implantation is expanding significantly with kids less than 1 year old, with kids with multiple diagnoses such as autism, Usher syndrome, for patients with the single-sided deafness, especially the one who have tinnitus or the one who wants to be very active in the life, patients who are old, more than 80-year-old, and finally, patients who have more residual hearing. So our research aim to protect this residual hearing so we can expand the indication even more. So I would like to recognize my team in my hearing research and cochlear implant laboratory, especially for this presentation. Dario Ebodi is one of my international scholar research fellow from France, who came to work with us to advance this field of cochlear implantation for a year. So I invite any of you who have students or would like to do some research to join us in our adventure with us and help to advance the science. And obviously, I would like to recognize my partner, my colleagues at the Ear Institute, both surgeon, audiology team that is very large and very effective, our psychologist, speech pathologist, educator, and social worker.
Thank you, Dr. Eshraghi. Thank you so much. And clearly from all the presentations, it shows how the advances at UHealth and how we're on the forefront in this area of otolaryngology has shown through. So let's go for our final poll question, and that is, which of the following are good indications for cochlear implantation? A, children less than 12 months with a profound bilateral sensorineural hearing loss. B, adults 85 years old with a severe bilateral sensorineural hearing loss. C, adults 50 years old with a profound single-sided sensorineural hearing loss. And D, children more than 24 months with a moderate bilateral conductive hearing loss. Or E, none of the above. Let's give them all a chance here, our participants, Dr. Eshraghi, to answer and see how closely they paid attention. And I tend to think that they were paying very close attention. And the results are, the majority answered A, 82%, Dr. Eshraghi.
This is great. I think A, B, and C are the correct answers because we know that all of these 3 categories are good candidates. D are not good candidate because if patient has a moderate bilateral conductive hearing loss, the patient can benefit from other procedures, such as maybe if there's a fluid in the ear, the kid can have tubes that can drain the fluid, or if it's because of some other issue in the middle ear, they can have a hearing aid because of moderate hearing loss. But A, B, and C are both, the 3 of them are good candidates. Thank you.
Wonderful. And Dr. Civantos, I'm going to turn it over to you. I know that we've had such thorough presentations. We're running a little over, but please take it away and how you would like to wrap up this evening.
Thank you. So as you can see, there's been a lot of progress in all divisions. You know, one of the reasons that otolaryngology and head and neck surgery have had such progress is subspecialization. And you can see here 3 different divisions: the Rhinology division, the Otology division, and the head and neck surgical oncology division. And you can see how, although we're all in one department, we all do such different things. We don't have a lot of time for questions. I think maybe we'll take 2 minutes. I had one very quick question as to what the next horizons were. And I would say that there's still work to be done on both robotics and Sentinel node, but eventually someday we may actually see the 2 combined, and maybe we'll be doing Sentinel node along with robotic surgery for oropharyngeal cancers. But we need to really not be experimenting on both at once. So once we decide robotics has a role and exactly where the role is and delineate it in detail, then we can start experimenting on the neck in those patients. So, but I think that that might be one horizon that we see. And I have one question for Dr. Levine, and then we'll just wrap it up. Karina, is there a role for, and this is off the Q&A, so, you know, we can't answer every question, but is there a role for chemotherapy in, before surgery in some of these patients with orbital involvement? And is that before or after? How does that work?
Yeah, so there definitely is a role for chemotherapy, and I think even immunotherapy, depending on what we see in our pathology. So I think one of the ways that we've been deciding is kind of partly with the rapid progression, but also with the tumor type. So I think that we have had a few systematic reviews and some smaller reviews that have come out of literature looking at skull-based tumors and the role of induction chemotherapy as another way to try to preserve orbital function. And there has been some success because in certain cases it will downstage our tumors and will make it an easier resection. And that's definitely something to consider. It certainly also depends a little bit on the patient and the patient's appropriateness and also their willingness to undergo induction chemotherapy. The delays that I talked about in chronic sinusitis are pretty common also in some of our skull-based patients, so that we're usually right on the border of whether we can do something endoscopically or not. That said, even afterwards, there's certainly a role to be looking at chemotherapy and sometimes even immunotherapy, depending on some of the markers that we're seeing. So I think all of those options are open. One of the things that we do very well here is to discuss these patients at tumor board. And in fact, our skull-based patients get discussed at 2 tumor boards, so that we really get a breadth of information and also people's experience as far as choosing a surgical resection versus choosing induction chemotherapy. And that's something that we make as a group decision as opposed to an individual, and is one of the great advantages of having an institution like the University of Miami, where you have such depth and breadth in so many different areas, not just in surgery, but radiation and chemotherapy, and even experts in immunotherapy.
Thank you. So when I was in my training in the early 90s, we were taught that there was no cure for sensory neural deafness. And it's just amazing to hear Adrien talk about cochlear implants. It still fascinates me. What was a deafness that couldn't be fixed has now become a major part of surgery. And that's why, you know, the screening of deaf children has become such an important thing, and picking up these profound sensory neural hearing losses in the very young. I had the opportunity a few years back to go on a medical mission and in Central America, and encountered children who were deaf that were just beyond the age where they can be cochlear implanted. And it really reminded me how nice it is that we have the opportunity to screen and pick up children in the United States. And Adrien, I couldn't pull all the questions off the Q&A for you, but I thank you for that talk. That was excellent. Karina, I really thank you for your talk. I don't know if you all realized she basically took a tumor from the brain out through the nose. And if you weren't impressed by that, I sure was. So I think I'll leave it at that. And I'm very grateful to have been able to be on the same panel with my 2 colleagues who did such fine presentations, and thank you for the opportunity to really participate in this international panel.
Thank you so much, Dr. Civantos, really, and for all of you expert panelists taking the time after a long day today, and to our great global audience joining us from all over the world. I think you already know that the University of Miami Health System appreciates your participation and ready to care for your patients. So please visit uhealth.org to learn more about the topics covered tonight, uhealthinternational.com to refer your patients for virtual or in-person appointments with our experts. Complete the survey at the end of the talk to provide some feedback and some future topics. You all take care of yourselves, have a great night, and please stay safe out there. Good night.
Thank you.
Thank you.
He didn't take my question.